Okay, so we'll just make a start on today's webinar and people can join in the next couple of minutes. So hi everyone, thank you so much for attending today's ISBNPA webinar on the topic of promoting health behaviours and rehabilitation for teenage and young adult cancer survivors. The webinar is presented today by the Special Interest Group Cancer Prevention and Management, and we have two speakers for today's webinar who I will introduce shortly. And the plan is to have a very brief introduction, which will sort of last around 5 minutes. Each speaker will present for approximately 15 minutes, and then we will have around 15 minutes for some questions and answers before closing today's webinar. So I'm just going to very briefly cover some general housekeeping just before we move on to today's speakers. So as part of ISBNPA, these webinars are organised as an extra service for our members, and these webinars are organised by the special interest groups of ISBNPA. And you can see a full list of the special interest groups and how to join them on the ISBNPA website. And the link to access that information is on the screen here as well. On this website, you'll also be able to find information about upcoming webinars, and you'll also be able to access webinars which have been conducted in the past as well. And very briefly, just to give you an overview of our group. So the Cancer Prevention and Management Special Interest Group, the aim of our group is to promote lifestyle interventions and behaviour change. And as part of this, it covers prevention, screening, early detection, and lifestyle interventions for people who are living with and beyond cancer. The group also aims to develop a multidisciplinary international group of researchers who combine the expertise of relevant behavioural, physical activity, and nutrition disciplines. And obviously, all of these factors are really important for informing policy, public health, and for developing interventions as well. And just briefly, our group is made up of the following executive team. So you've got Becca, who is the chair of the group, and Cindy, who is the deputy chair. Linda is the past chair for our group, and Zan is a former treasurer for the group as well. Emily is one of our communications officers, and Jordan and Laura are the social media officers. Leanne is our secretary, and I am the webinar officer. And we currently have positions open for a social media and a treasurer role. So if any of you are interested in any of these positions, then please do drop any of us a message. If anyone is interested in joining the committee more broadly, so for example in roles such as a secretary, then we will be really happy to discuss this with you. We're really keen to hear from students and early career researchers as well. Okay, so I'm just going to move on to Becca, who will briefly discuss the Cancer SIG and the UK Society for Behavioural Medicine. So Becca, I'll pass over to you.
Thanks, Hannah, and thanks everyone for joining us today. So these particular webinars are jointly organised by ISBNPA Cancer SIG, but also the UK SBM Cancer SIG and the SBM Physical Activity SIG, which Linda's going to talk a bit more about in a moment. But for those of you who aren't familiar with UK SBM, this is a network of academic and clinical health researchers who are interested in applying knowledge, theory and evidence on health-related behaviours to improve the health and well-being of people in the UK and beyond. And the Cancer SIG is focused on providing a forum for the exchange of ideas, knowledge, information and best practice for those interested in the application of behavioural medicine to the prevention of cancer, screening and early diagnosis of cancer, and health behaviours among those living with and beyond cancer. So very much aligned to what we do within the Cancer Prevention Management SIG within ISBNPA as well. The UK SBM Cancer SIG has a LinkedIn group, and there's a QR code there if you're interested in joining. And they also, in addition to these joint webinars, they hold additional webinars and journal clubs. All of the info for those is on LinkedIn, and they're also always keen to hear from people who'd like to present. So please do feel free to get in touch with them if you're interested. In terms of the UK Society of Behavioural Medicine, Hannah, could you just go to the, thank you. So if you are interested in joining, it's a very reasonable membership fee, and there are a number of benefits to joining, including access to a mentoring program, free membership to ISBN, discounted fees for conferences, as I've mentioned, several webinars, and access to a number of other events and journals. I'll hand over to Linda now to talk about the physical activity SIG.
Thank you, Becca. So as a former PA SIG chair, I'm representing the PA SIG on behalf of the current leadership. So the physical activity SIG is currently being led by Drs. Rodney Joseph, Natalia Heredia, and Dr. Denver Brown. The SBM is actually based in the United States, and it's one of the nation's leading groups of multi-specialty clinicians, educators, and scientists dedicated to improving the health and quality of life via proven behavioral science. Within SBM, there are a number of special interest groups. There are over 20 special interest groups that members can join across a variety of different behavioral medicine interests, and the physical activity SIG, or the PA SIG, is one of them. So the mission of the PA SIG is to update members on the latest initiatives related to the physical activity field, provide a format for both formal and informal networking among members with physical activity interests, and they serve as a forum for advancing physical activity research through developing submissions for the SBM conference, mentorship opportunities to junior members, dissemination of public-facing articles, just to name a few, and of course, supporting international webinars like this one. The website to learn more information about SBM is sbm.org. You can see all of the membership benefits that you can access there. There's also a X page you can access at SBM_PASIG. So I'll turn it back over to Hannah. Thank you.
Brilliant. Thank you so much, Becca and Linda, for those introductions. So just for today's webinar, you'll all be muted except for the speakers and the organisers, and this just helps us to prevent noise during the talks. If you do have any questions or comments for either of our speakers, please either put your questions specifically in the Q&A function or virtually raise your hand. But please bear in mind that we will only get round to questions after both of our speakers have finished their presentations today. Okay, so moving on to the exciting bit. So today we have presentations from Mr. Scott Capozza and Miss Jennifer Fitzpatrick. Scott is from the Smilow Cancer Hospital at the Yale Cancer Center in Connecticut, and he will be presenting on rehabilitation needs and strategies for young adults with cancer. His talk will address barriers and psychosocial concerns that might impact the ability of young adults to access rehabilitation services. And then we'll have a presentation from Jennifer, who is from the Technological University of the Shannon in Ireland, and she will be presenting on the Childhood and Adolescent Cancer Survivors Physical Activity and Movement Programme, also known as CHAMPS. Her talk will discuss the development and implementation of CHAMPS, and this uses a patient-centred and evidence-based informed approach as well. So I'm just going to stop sharing my slides and I will pass over to Scott to begin his presentation. So Scott, over to you.
Thank you.
All right, great. Thank you so much. I'm very excited to be a part of this today. I enjoy these international collaborations. This is an exciting opportunity for me, and to take a little time to talk with you this morning or this afternoon, depending on where you're logging in from, to talk to you about the needs of the adolescent and young adults with cancer and how we can engage them more in rehab and in physical activity. These are my disclosures. These are my learning objectives. So again, I'm going to take the first couple of minutes to kind of talk about who are AYAs, young adults with cancer, and explain, why these young adults are different than our older adults who are diagnosed with cancer, and what are their unique challenges and barriers that they face in life in general, as well as to rehab and exercise specifically. And I'm hoping that I can just set the stage for Jennifer to then talk about her work and some of the practical ways that we can engage our young adults with cancer in rehab and exercise. So quickly, definitions. I have noticed that, across the globe, the definitions of a young adult with cancer vary a little bit. I know our colleagues in Australia, for example, define young adults with cancer a little bit younger, more towards the 15 to 26-year-old age range. But it seems that as for North America, as well as most of the European countries, adolescents and young adults are defined as the group between 18 to 39 years old. And again, you can see the numbers there of the number of young adults diagnosed in several different countries around the world. And one of the things that makes young adults different than other populations is that they're in this transition phase. They're not pediatrics, and they're not older adults. They're almost sandwiched in between these two, these two areas of development. They're not completely dependent on somebody. They're not completely dependent on their parents as if they were a child. But they haven't been working for 20 years. They may not necessarily have been, married for 20 years, and they have adult children. They're in this transition phase. And one of the issues is that because they don't necessarily fit into a good bucket, so to speak, there's not a lot of literature out there to help support our AYA, specifically when it comes to exercise and to rehab. And again, for the young adult who maybe faces a cancer diagnosis during this age range, there's all sorts of social disruptions that can occur. So for our young adults who are maybe under the age of 18, the struggle is to try to finish high school, to get that high school diploma, that's going to delay their opportunities to go get a job and be able to live independently. For our young adults who are between the ages of 18 and 25, where maybe they're going to, the university, or they are getting that first job, those might be put on hold while our young adults, are dealing with a cancer diagnosis and are dealing with cancer treatment. And then for our young adults who are between that like 26 to 39-year-old age span, that is a time when young adults are really trying to come into their own financially. This is the time that they're going to get those jobs and start their nest egg, so to speak. Their relationships are looking differently rather than maybe relationships that last shorter periods of time. They're thinking about a life partner. And all of those can be interrupted if a young adult is diagnosed with cancer during this time frame. Again, for our that emerging adulthood phase, they're independent, so to speak, but they may still use their parents' address for their point of reference. And here in the United States, young adults can stay on their parents' health insurance until the age of 26. So this may actually lead to what we would consider insurance naivete, that young adults in their early 20s don't have to worry about what's a copay and what's a deductible and those sorts of things because they're on their parents' insurance, and so they never had to deal with that before. And then as they transition into young adulthoods, again, they're transitioning into their workforce, and those relationships are changing. Again, they're going from maybe relationships that aren't necessarily long-term to thinking about long-term relationships. Finding a spouse, finding a partner, somebody to settle down with, and the financial responsibilities become even more significant during this time. And they're trying to figure out how to balance, their income versus their expenses. This might be the first time that they're paying their cell phone bill on their own, to pay their utilities. Maybe, they shared a house with several friends previously, but now they go out and they buy their first condominium. And so there's a lot of different financial responsibilities that come with that, and learning how to, balance that checkbook. Very briefly, we see the different types of cancer that we see in the young adult population. It is interesting to note that that thyroid cancer is probably the most prevalent. Of course, both the 20 to 29-year-olds and the 30 to 39-year-olds. And it's been my clinical experience that our patients with thyroid cancer also have a lot of physical needs. They have a lot of psychosocial needs. I look at it as, our patients with breast cancer, they can kind of hide their scars. Our patients with testicular cancer, they can kind of hide their scars. But if you've had a thyroidectomy and it's kind of hard to hide that incision, to hide that scar, which again, if you're out dating, you're trying to create these long relationships, how do you hide that? How do you have that conversation? It is important to note that cancer in the AYA population is increasing. At least here in the United States, what we're seeing is that the total number of women with breast cancer is growing the fastest between that 30 to 39-year-old age range. And colorectal cancer is also showing the fastest growing incidence in our young adult population. And we're not quite sure why. Maybe part of it is genetic. Maybe part of it is, at least again in the United States, there's a bit of an obesity epidemic. But also to know that most of the screening recommendations don't include the AYA population. Screenings for breast cancer, for example, to have mammography is, it doesn't start until the age of 40. Colorectal screenings, at least here in the United States, was 50, the age of 50, and it's been lowered to 45, but that still doesn't cover the AYA population. And so these patients are not getting these regular screenings like our older adults do. So that's why a lot of these cancers are more aggressive. They're more in this, potentially the stage 3, stage 2, stage 3, because they're not getting those routine screenings like our older adults do. Why our young adults are unique compared to, again, our older adults: fertility preservation. Our young adults who are in their 20s and 30s are maybe thinking about starting a family versus somebody who's in their 40s or 50s or 60s. They've already had a family. Body image concerns, which again is such a concern for our patients as they're trying to maybe re-enter the dating scene after they've had a cancer diagnosis. Have they put on weight because of steroids? And so how do they perceive themselves now? There's definitely this mourning of their pre-cancer life. And I think it is important to note that because our young adults are diagnosed at a younger age, they're going to potentially, hopefully, have a longer lifespan, which is obviously a great thing. But that just means that our young adults have more time, more opportunity, so to speak, to develop these late effects. Somebody who's diagnosed at 30 hopefully will have decades of life ahead of them, which means they're at increased risk for cardiovascular disease, pulmonary disease, secondary cancers because of the very cancer treatments that kept them alive, versus somebody who's diagnosed in their 60s or 70s. So somebody who's diagnosed in their 60s or 70s, they might only have, 20 years of life ahead of them versus somebody who's 30 who potentially has 50 years of life ahead of them. And that's a lot of time for these late effects to pop up. I do want to take a moment to talk about financial toxicity because, again, I think the AYA population is much more susceptible to this than our older adult population. Our young adults, again, are trying to establish their financial stability in their 20s and 30s. They don't necessarily have the amount of savings that somebody who's been working for 30 years has. They're also going to be making less money. Their income as a new graduate, so to speak, or somebody who's been out of school for 2 or 3 years is not going to make the same amount of money than somebody who's been out of, they graduated 25, 30 years ago. And again, because of sometimes this insurance naivete, these medical bills build up and they don't know how to balance their checkbook. They don't know how to manage these finances or these financial responsibilities. And so we oftentimes see these young adults having to move back in with their parents, which again contributes to their sense of independence. They were trying to be independent. They were trying to get their own apartment for the first time, really kind of be on their own. But if the medical bills keep piling up and they're not able to keep up with them, they might have to sell that condominium or not, or break their rent, move back in with their parents. And we do see this here, at least in the States, where patients sometimes will have to do this crowdsourcing, like GoFundMe pages, that sort of thing, in order to be able to help pay for some of their treatments. And so again, our AYAs kind of get stuck in this cycle of financial toxicity. If they're not working as much, they have to take more time off because of treatment. They don't have health insurance, or the health insurance is not great. And combine that with the rising cost of oncology medical care and this inability to cover those essential costs of living, our AYAs feel like they're walking on a tightrope. Do they have enough money to, again, pay their bills, to pay their cell phone bill, to pay their electric bill, to pay their rent, to pay their college loans back? These are all concerns that we see so much more in the AYA population, and not as much compared to the older population. And again, we need to be cognizant, especially for those of us that work in rehab, for those of us that work in exercise oncology, that to tell our patients, we want you to come in for rehab, we want you to come in for physiotherapy, to help you with your side effects, your range of motion, your fatigue, that sort of thing. That's all well and good. But if they have to travel to come see us, they have to pay for parking, they have to pay for gas. If they have young children at home, they might have an 18-month-old child at home. You definitely can't bring that 18-month-old child to an infusion center, and you probably can't bring them to a rehab office either. And these out-of-pocket costs can add up. And we have to be cognizant, especially as physiotherapists, that these out-of-pocket costs, including our co-pays, build up over time. And does that further contribute to financial toxicity? Another thing that can contribute to financial toxicity, which again is unique to the young adult population, is fertility preservation. Our young women, and also our young men, if they're trying to do cryopreservation for sperm banking, have to pay for fertility preservation and for fertility treatments. And so often they're not necessarily covered, or not covered in full, by health insurance. Cryopreservation oftentimes is not covered by health insurance. And I'll give you a quick example of what I had to deal with as a young adult myself. Where I work, there's two different departments. There's Yale University, which is one entity, and Yale New Haven Hospital. They're two very different entities, even though they share the same name, Yale. If you work for Yale University, you get 4 cycles of fertility treatment covered by your health insurance. You don't have to pay a copay. You don't have to pay, for blood work. You don't have to pay for any of it. And that's amazing. But if you work for Yale New Haven Hospital, if you are a hospital employee, so you are a nurse, you're a support staff, you're a physiotherapist working for the hospital, it is capped at $10,000 a year, which does not even cover 1 cycle of fertility treatment. And so right there, you can see the discrepancy of how something like fertility preservation and fertility treatments can be so, such an impactful thing for our young adults, and how that contributes to financial toxicity. I'll quickly go through this, some of the issues that we see with our young adults that are treated with breast cancer. And one of the things we have to be mindful of for our young adults with breast cancer is that if they have hormone therapy positive breast cancer, then they will probably be put on ovarian suppression medication, which is going to thrust our young adults, our 30-year-old, our 33-year-old woman with breast cancer, it's going to thrust them into menopause, potentially 15, 20 years before that's supposed to happen, which means that they're going to be having all of these menopausal side effects, which is going to include joint pains, and it's going to include decreased bone density. And this can all contribute to decreased quality of life. And so again, as physiotherapists, as those of us that work in exercise oncology, we need to be mindful of that. If our young women with breast cancer are put on hormone suppression therapy, that we need to make sure that we're doing weight-bearing exercises with them, because even though they're 35 years old, they're skeletally, they may look like somebody who's 65 years old. Again, quickly for testicular cancer, these are some of the issues that we see as far as surgical interventions, chemotherapy, and radiation therapy. And then for our hematologic cancers, again, we need to be mindful of cardiotoxicity, neuropathy, pulmonary toxicity from bleomycin. That's used less and less in the testicular cancer population now. But if you have somebody who was treated with testicular cancer 20 years ago, and they come to you for an exercise prescription, and they had bleomycin, that is definitely something to be screening for. Do they have any kind of pulmonary issues because of that? So some of the ways, briefly, to talk about how do we overcome some of these barriers to engage our young adults with cancer in rehab. If you're in the inpatient setting, it's so important to coordinate our care with nursing, to be able to schedule our appointments with them around any kind of testing that they might have, any kind of scans, any kind of blood work that they might need. And so constant communication with the nursing staff is critical here. And I think it's important too to talk with your AYAs to find out what are their goals. What do they want to do? Is it, they want to, they're working towards regaining their strength so they can get out of the hospital so they can return to university. And, if they're at university, then they have to walk around campus. They have to carry a backpack. And so those would be some of the functional things that, that you could be working with your young adult with cancer in an inpatient setting. In the outpatient setting, it is so important that we identify these out-of-pocket costs upfront. For our physiotherapists, it is important for us to know, what is that patient's copay? Is it $10 or is it $40? Because that makes a significant difference. And if that patient's out-of-pocket cost, their copays is $40 or $50, maybe we need to space out our sessions. Instead of saying, I'll see you twice a week for, for the next 8 weeks or whatever, maybe we have to space that out and say, well, I'm going to see you every other week. And I'm just going to make sure that you really drill down on your exercise that you're supposed to be doing at home. Do we offer telehealth options, to save them money on gasoline, and to save them money on parking, time away from work? Maybe we offer telehealth options for them rather than having them come into our clinic, if that's easier for them. Again, working around their schedule, their work schedule, because they're trying to get back to work, work around their university schedule if they're still in the university. And if they have young children, if they have a little one who's in preschool, then say, okay, let me see if I can see you in the morning after you drop your little one off at preschool. You've got that little window of time that I can see you. And then when we're done, then you can go back and pick up your little one, at lunchtime from preschool. It is important for all of us, even though, some of us may not necessarily be trained as mental health professionals. It's important to ask the questions and know that if our patients are experiencing any mental distress from fear of missing out, fear of recurrence, anything like that, that we can at least start that conversation, and then know that, again, as physiotherapists, or personal trainers who work in exercise oncology, to make sure that we're making those referrals to our social work colleagues or our psychology colleagues to make sure that they are addressed appropriately. Again, screening for financial toxicity. And then again, to work with our providers to make sure that they're getting those patients to us in a timely fashion so that they can return back to university, they can return to work, and they can return to their lives. I always like to try to direct my young adults to any kind of online resources, especially in 2025. There's so much misinformation that's out there. And so to be able to direct our AYAs to credible sources, for psychosocial support, for physical support, for financial support. So these are some of the ones that I will send my young adults to, because they're, at this point, the young adults that I see now are much more savvy on social media than I am. But I at least have to know what are the credible sources and resources to send them to. So my take-home message right here is to say that if you're working in physiotherapy, or you're working in exercise oncology with a young adult with cancer, a lot of times our interventions are very similar as far as how we would address somebody post-surgically, or somebody who's going through chemotherapy, or somebody who's after radiation therapy. But again, to be cognizant of those unique challenges that AYAs face, again, like fear of financial toxicity, fear of recurrence, fear of isolation, and again, those late effects that, because when they're diagnosed in their 20s or 30s, those late effects may show up 10, 15, 20 years later. So if that person is walking into our clinic at that point, those are the things that we have to be mindful of and screening for. These are my references. And that is my presentation. This is me with my kids doing our bike ride for our cancer hospital.
Thank you so much, Scott. That was a really great presentation, and I'm sure that we'll have lots of questions to go through at the end. So I'm just going to move over to Jennifer, who can start her presentation now. So Jennifer, over to you.
Perfect. Thank you very much. Thank you very much, Scott, as well. Perfect. So thank you everyone for joining this webinar today. I see some familiar names from Ireland. So thank you as well for joining. I'm delighted to be here today to share with you the development and evaluation of a patient-centered, evidence-based and theoretically informed physical activity behaviour change intervention for young people who have had cancer. And my presentation today will be broken down into 4 different sections, including figuring out what is missing, talking you through how we actually developed a program, what's involved in the program, and then why is this research important. So first of all, we know that up to 1,000 young people are diagnosed with cancer each day worldwide, and up to 90% may be living with side effects after treatment. However, there's limited physical activity interventions for young people after treatment, and this results in a missed opportunity to improve their quality of life, given that we do know that physical activity can have such a positive impact on the physical functioning, emotional well-being, and quality of life of young people who have had cancer. But there's also limited evidence regarding how to effectively increase and sustain physical activity levels among young people who have had cancer. But in addition, then, there's limited use of behaviour change theory and family involvement in programmes or interventions that are available. And this is where my research can support families through its evidence-based, patient-centred and theoretically informed approach in creating an intervention or a programme. But how did we actually go about this process? So this process took over 2 years, and it was guided by the Medical Research Council's framework for the development of complex interventions. And over the 2 years, we had 5 different phases, including reviewing scientific literature, completing a qualitative investigation, applying behaviour change theory, to then create a prototype of the programme, to then share it with our experts in a stakeholder workshop. So now I'll talk you through each of these stages as to how we actually went about this process. So first of all, the primary aim of our scientific literature was to identify the determinants of physical activity behaviour, maintenance and adherence, but to also identify previous physical activity interventions that were successful in increasing physical activity within this population, but to also identify specific behaviour change techniques that were associated with their success. We included papers up to 2023 where physical activity or exercise was the primary outcome, and we excluded multimodal interventions. The second stage was to identify the challenges and solutions with regard to physical activity and dietary behaviour before, during and after treatment, but to also gain families' recommendations for a lifestyle programme. And we included teenagers aged 12 to 16 years old who had completed active cancer treatment, young adults, parents of teenage or young adult survivors of cancer, and also healthcare professionals that work in cancer care. And we completed interviews that were conducted online or in person. They were audio recorded, then transcribed, and then we analysed it using thematic analysis. The third stage of this process was to look at all the different behaviour change theories that have been utilised worldwide within this population. Some examples included the self-efficacy theory, social cognitive theory, our self-determination theory, or called experiential learning. However, we decided to go with the behaviour change wheel as our selected framework that has the COM-B, so our capability, opportunity, and motivation theory within the green circle in the centre. And the reason why we went with this framework was because it synthesizes 19 existing individual theories, and then it draws from the strengths of each of these. But how did we actually apply this? So first of all, we identified the target population and our target behaviour that we wanted to change. We then linked this target behaviour to intervention functions, which you can see as the red circle on the wheel. We then selected our behaviour change techniques within this, and then we mapped all of this together, and then we created intervention components. Our fourth stage was combining all of the first three stages that I've just mentioned. So we synthesized our scientific literature, we spoke to families and healthcare professionals, and then it was guided by theory. And from all of this, we then created a prototype of our program, which was called CHAMPS. CHAMPS was then shared with our stakeholders, so the experts, to determine the acceptability of the prototype, but to also gain recommendations for intervention improvement. And we spoke to young people who have had cancer, their parents, young adult advocates for cancer survivorship, but also child and adolescent cancer charity representatives. And this took place over 2 online workshops to suit participant availability. And then I facilitated discussions regarding each intervention component within the proposed prototype of the intervention. But what exactly did that look like? So I've spoke about how we went about it, but what are the specific findings or results from each of these phases? So overall, we had approximately 26 statements of findings generated from looking at the literature. And here I have some examples as to what that actually looked like. So first of all, if we look at behaviour theory, so it's recommended that we include motivational interviewing techniques and also behaviour change techniques such as social support, instruction on behaviour, and behavioural practice. With regards to physical activity preferences and prescription, it's recommended that an intervention includes multimodal physical activities, such as strength, flexibility, balance, or endurance, that there is inclusion of a supervised element, but also to include both practical and educational components within the intervention. Research has shown that lower levels of physical activity are associated with being female, being an older adolescent, being overweight, or having had a central nervous system tumour. Research has shown that higher levels of adherence to a programme are seen with young people that are involved in decision-making processes regarding the type of physical activity that they would like to take part in. And we also see higher retention rates among a home-based programme that's personalised to each young person. And this then can support increases in their autonomous skills and their self-management of their exercise or physical activity behaviours in their own environment. Our qualitative analysis, we had 31 participants take part, and we had 10 adolescent or young adults, where we had 70% female and 40% of this cohort had a brain tumour. We had 12 parents, where 92% were female and 42% of their children had a brain tumour. But we also included healthcare professionals working in cancer care, where we had 9 healthcare professionals with 67% female and 1 representative from each of the following professions you can see on screen. So from this qualitative investigation, we did generate 4 themes. However, for the purposes of this presentation today, I'll just be sharing the recommendations generated from the 4th theme, which was family and healthcare recommendations for a programme, in which they suggested a 12-week programme that included 1 session each week for 60 minutes, that was both in person and online, that included both practical and educational components, that included whole body fun activity that focused on muscular endurance, aerobic, balance, and so on, but to also have the family involved in the program itself. Next, if you think of that third stage where I went through the methods of how we did it. So as you can see on the rectangles on screen, these were the stages that we went through. So our first stage was to select our target behaviour. And in this instance, we wanted to increase physical activity levels among young people who have had cancer. We selected those intervention functions, which was the red circle. Here are the ones applicable to this research. We then selected behaviour change techniques, such as social support, goal setting, action planning, and so on. And then we mapped all of this together. But how did we actually map it together, and what does this actually look like? So here I have just one example of what this looked like on how we got to the CHAMPS programme. So if you think of the statements of findings or are looking at the literature to see what is available, we can see that supervised exercise sessions resulted in higher adherence and retention rates among childhood and adolescent survivors of cancer. We then link this to the very, very inner circle of our behaviour change wheel, where we identified physical capability, physical opportunity, and reflective motivation as aspects that need to be included. We wanted our intervention functions to include education, persuasion, incentivization, and so on. We looked at our qualitative investigation with families in Ireland, where they discussed the importance of a supervised physical activity session. We then selected numerous behaviour change techniques. Here I just have a few on screen, such as problem solving, action planning, feedback on behaviour. And then ultimately, all of these stages added up to create our intervention component, which included a home-based supervised physical activity session. And then from this, we created our actual prototype of the programme, which we then shared with our experts, which they deemed feasible and acceptable for young people who have had cancer. And they also generated numerous recommendations on how we can improve the programme prior to actually rolling it out to families in Ireland. And now, what exactly is included in the programme? So as I mentioned, CHAMPS was the ultimate output of that 2-year-long intervention process. But what is CHAMPS? So CHAMPS is a free 12-week personalised home-based physical activity programme for young people aged 10 to 19 who have had cancer. And CHAMPS takes place completely in the young person's home and is entirely guided by their ability and their interests for physical activity. So to our knowledge, CHAMPS is the first of its kind in the world, and it is delivered by me. And as I mentioned, it's a multi-component programme that includes Let's Move Like a Champ, Let's Learn Like a Champ, our CHAMPS Toolkit, Becoming a Champ, and then also progress tracking. So our Let's Move Like a Champ component, this involves 12 weekly personalised sessions where the first 8 are in person in the young person's home, meaning I physically travel to that young person. And then the next 4 sessions take place online through Zoom. And all sessions are guided by the young person and how they're feeling on that specific day. Next, we have Let's Learn Like a Champ, includes 3 family-based interactive educational workshops that are 15 minutes in duration. And within these workshops, we learn about the science of physical activity and exercise, but also how physical activity can support the management of side effects that the young person may have. Becoming a Champ includes 3 family-based workshops that are 15 minutes long, and the focus of these workshops is on how we can support the young person to succeed in making physical activity a part of their everyday life. And within these workshops, we utilise our motivational interviewing techniques. And then we also have our CHAMPS Toolkit. So within our CHAMPS Toolkit, we have our Let's Move More, which is a practical information booklet for families that contains physical activity resources, but also a participant self-selected equipment kit bag to enable the young people to be active in their home environment. Now, if we think about the actual trial itself, so I've gone through the components of the programme, and CHAMPS is being delivered as part of a research study through a feasibility trial, where the primary aim is to see, is the delivery and implementation of a physical activity intervention for childhood and adolescent cancer survivors feasible? And under the domains of feasibility, we are looking to see, is it acceptable? Is there a demand? How can we implement it? Is it practical? How can we adapt it? And what is the limited efficacy of the actual programme itself? Now, if you think about the multi-component programme, so we have Let's Move Like a Champ, Let's Learn Like a Champ, Becoming a Champ, our Champs Toolkit, but we also have our progress tracking, and this comes under the trial as well through our assessment outcome time points. So young people complete their progress tracking before and after they start the programme, and then also we follow up 3 and 6 months after they complete the programme. And we're looking at their physical activity by wearing a physical activity 3 micro for 7 days, and also by completing the PACE Plus questionnaire. We're looking at their physical functioning through the 3-minute step test, 30-second sit to stand, their handheld dynamometer, the Berg balance scale, and also their timed up and go. But in addition, we're looking at the PEDS quality of life inventory, the cancer module, and also the multi-dimensional fatigue scale questionnaires for these young people. So they're completing their physical activity, physical functioning, and then also quality of life assessments at all 4 time points. CHAMPS itself had a rolling recruitment, but within that we had 3 distinct starting points as such. So our first CHAMPS cohort began in April 2024, our second in July, and our third in October. And we are currently in the data analysis or interpretation phase at the moment. And in terms of our CHAMPS participants, here you can see a visual representation of where our CHAMPS families are located all across the island of Ireland, so our total of 16 families. And the home represents exactly where I am based in the centre of Ireland in the Midlands. And within our CHAMPS cohorts or our families, we had 44% that had a brain tumour and 25% lymphoma. Participants had received multiple treatment modalities, including chemotherapy, radiotherapy, surgery, and steroids. Our mean age was 14 and we had an equal gender split. So in terms of the feasibility trial and the results from this, they will hopefully be available in summer 2025. And just to finish on, why exactly is this research important? So we know what's missing in terms of that patient-centered, evidence-based, and theoretically informed intervention. We've created an intervention and we're currently evaluating it. But why exactly is this important? So we know to our knowledge that CHAMPS is the first global intervention that is entirely home-based. And this is providing valuable data for the childhood and adolescent cancer community through its feasibility study. But it has also addressed that identified gap of programs that are lacking that patient-centered, evidence-based, and theoretically informed development process for future researchers to use. But in addition, it's also providing evidence to advocate for improved supports for young people who have had cancer in Ireland. I would like to give a special thank you to all families who have participated in this research, my incredible patient advisory group, supervisory team, co-funders, the Irish Cancer Society and Technological University of the Shannon, the She Research Centre, and also Canteen Ireland for their incredible support throughout the whole 4 years of my PhD. Thank you very much.
Thank you so much, Jennifer, and thank you again, Scott, for your presentation as well. So we've got probably around just under 10 minutes for some questions, and I can see that we've got one question in the Q&A function, and this one is for Jennifer. So if anyone does have any questions, then please feel free to either put them in the Q&A function in Zoom or to pop them in the chat, and we will get round to those. So the first question that we have is from George, and it's for Jennifer, and it says, how do you find the difference in engagement between the in-person and online sessions, and do you think that both can be equally effective for rehabilitation?
Yes, so first of all, a bit of background as to why we included both the in-person and online sessions. So if you think of the qualitative investigation where we spoke to families with the lived experience of childhood and adolescent cancer in Ireland, their recommendation was to include both in-person and online sessions. And then secondly, from I suppose a behaviour change point of view, I'm quite supportive in the family home. So for example, we're just in the sitting room or the kitchen or the garden of that young person's home where I'm physically with them and we're increasing their confidence with being active in their home environment. We might be slowly introducing new activities, showing them their physical capabilities and what they're interested in, but then I'm slowly withdrawing that support. So I'm still supporting them through the online environment, but I'm physically not in the home. So they're increasing their independence with being physically active in the environment. We're also currently running focus groups with all of our CHAMPS graduates to see how we can improve the program for the future. So that may be something that might come up regarding the online and in-person, I suppose, the effectiveness of that. So hopefully if you stay tuned, we might have some results as to more feedback on that. Thank you very much for the question.
Great, thank you so much. We've just got another one, a couple in the Q&A function and also in the chat as well. So I'll just do them in order, and then just in light of time, I'll make sure we get round to some questions for Scott as well. So we've got a question from Debbie, which says, have you looked into the sustainability of the programme, Jennifer, and will this be costed into rehabilitation programmes?
Yes, so the CHAMPS was completed as a feasibility study. So it's the very first step in seeing can it actually be ran. We're currently looking into possible postdoc funding to see is it sustainable long term. So we are looking at like an economic evaluation to see can it be implemented as a service in the future, as say like a formal service. So that is our next step. So well done on thinking of that question.
Fab. And then another question in the Q&A just before, I know Jordan Curry's got a question as well. So we've got a question from Helen, and it says, Jennifer, what was the most unexpected finding from your qualitative investigation, and what might you do differently? And then there's just a comment saying super presentations from Scott and Jenny. Thank you.
Ooh, good question. I think because obviously we included young people who've had cancer, parents, and then also healthcare professionals, there was such a shared opinion regarding that, yep, physical activity is important, but also there was a shared opinion regarding the lack of supports. And this was voiced from both the family perspective and the healthcare professionals. So they are on the same page. It's just that the healthcare professionals unfortunately don't have the capacity, given that the healthcare system currently don't have the capacity to deliver such supports post-treatment. So I suppose in terms of the unexpected finding, possibly may have been that there's such a shared opinion across perspectives within the childhood and adolescent cancer community.
Brilliant. Thank you so much, Jennifer. And then I think Jordan might, if you want to unmute yourself and just ask your question, Jordan, if you can. If not, I can unmute you.
I don't think Jordan can do that. Let me see if we can help him.
Yeah, okay.
Allowed to talk. Jordan, I think you can talk now and show yourself.
He's allowed to talk now.
Okay. There's no option for a camera, which is probably good for everyone. Thank you very much, Scott and Jennifer. They were two fantastic presentations. I was wondering in terms of the CHAMPS, and I know, Scott, I think you worked on the care AYA study and a few similar initiatives. What kind of recruitment strategies are you aware of that can improve the promoting recruitment or facilitating recruitment? Because I know in my own work that is probably one of the hardest things to get people involved in the trials. And with AYA being a unique set of individuals, I was wondering from your perspectives, what are some of the key effective recruitment strategies?
Do you want to go ahead first, Scott?
Sure, I'll go first. I feel like, Jennifer, you've had all the questions directed at you, so I'll start here. It's a great question, Jordan, and thanks for tuning in. I think one of the things that we need to think about as physiotherapists and those of us that work in the exercise oncology world is that we need to advocate for our young adults, and we need to start that conversation with the healthcare providers. And I especially think, because I think if I saw your question correctly, as far as like how do we reach our AYAs across different socioeconomic backgrounds and geographic backgrounds and that sort of thing. So especially for our young adults who are maybe traveling far, if they have to drive, a long distance to get to a major cancer center, at a big city like Dublin or like London or like, in the States in New York City, but they live an hour and a half, 2 hours away, that probably a virtual option to engage them is great. But our oncology nurses, our radiation oncology staff need to be able to start that conversation with them. And does that mean that maybe we push in? Do we try to push into those rad onc clinics, or do we push in, to those, to those clinics, to the infusion center once a week, and just say, hey, if there's any young adults, anybody under the age of, 35 or 40, whatever it is, to say, hey, can I talk to them for 5 minutes or 10 minutes about, the importance of exercise, and, Jennifer, to your point, to get a sense of what's important to them and what's the easiest way for them to access exercise and rehab. If they live closer and they want to come in person, fantastic. If they live an hour and a half away and they don't want to come all the way in, then a virtual option might be a better thing. So it is about meeting that AYA where they're at. And so we might have to physically go to where they're at to get, when they're still in the middle of treatment, to at least plant that seed. And then, do we follow up with them when they're done? I do think that, again, some young adults, and it's been my clinical experience that, a lot of young adults want to be in the community. They want to return to the gym, but they don't know how to get back to the gym. They don't trust their bodies. And so some of those in-person sessions are helpful to work with them on exercise pieces of equipment, and then have them then transition over to the gym. But again, I think if we can work that further upstream, that might help our chances of recruiting and engaging our AYAs at an earlier time frame. Jennifer, I don't know, what do you think?
Yes, I suppose from my perspective, the first study we did was our qualitative investigation, and recruitment was slow to this. The young people and their families, they obviously didn't know me. I was new starting the PhD. They'd probably only heard the name once or twice. But then when CHAMPS came around, I'd attended different family-based conferences through Canteen Ireland, an incredible support group for young people who've had cancer, attended some of their in-person activity days. So the young people got to know me as a person rather than, oh, this is Jennifer, the researcher. I think building rapport with the young people, and as Scott said, meeting them where they're at, is definitely an essential aspect as to their engagement in terms of getting recruited to a program, and that they trust the person that they're going to be working with. So I definitely think building rapport prior to them starting a type of program or so on. And this might just be through an initial consultation or a quick informal meeting, little strategies like that. But certainly building rapport with that young person, that they trust the person that they're going to be working alongside.
Perfect. Thank you so much. We're finished right on time. So thank you so much to both of you for your incredible presentations. I'm sure we've all learned a lot and will take away a lot that will apply either to our research and practice as well. So I have put a message in the chat to everyone. It's got Jennifer's and Scott's email address. They've been very kind in providing their email addresses to attendees in case we haven't got around to anyone's questions. But I just want to say a really heartfelt thank you for your presentations and for everyone who's attended as well. Thank you so much, everyone.
Thank you.
Thank
Bye-bye.
you.
Thanks for having us.
Bye.
Thank you. Bye.